like to ask Eric Staples to come up and take the floor.
All my papers. Thank you very much. Some of what you're going to hear is probably repetitive in some ways, because we all had the same three questions, and we came from this probably the same way I did and John did. We went back into the literature and looked at just what had occurred. So I'm going to take you through a bit of a journey tonight around the NP role. And as John had said, nurse practitioners were first introduced 4 decades ago. In 1967 in Halifax, one of the first programs began, and a post-program for nurses who were working in northern nursing stations. Later in the 70s, NP programs were developed. McMaster was a program that was developed. But as John said, the timing probably was not right at that time. There was a perceived, by the 80s, in 1983 was the last time that this program ran here at McMaster, a perceived oversupply of physicians. Regulation had now occurred, legislation had now occurred, and there was no really remuneration in place for the roles. So with all of that, the roles disappeared, but people who had graduated from those roles continued to function as nurse practitioners in many areas. And certainly when I was doing my post-RN work at Ryerson, one of those people, Ruth Nesbitt, was a nurse practitioner from the 70s and was teaching at Ryerson and became sort of a person I looked up to and had my first foray into what's a nurse practitioner at that time. In the 90s, I was living in Toronto, 92. 92 was a bad time economically. With the Ray government, there were lots of things happening in terms of hospitals in downtown Toronto were closing beds. Hospitals were being closed. There also was quite a decrease in the number of residents in the hospital. I was a clinical nurse specialist at the time in oncology at Women's College Hospital. And because there was such a shortage of residents, patients didn't always receive timely care when they should have. And a good example for that was chemotherapy may not have been administered sometimes till 1 in the morning. So the patient was sick all night long. There wasn't enough people around to look after patients that were vomiting, symptom control, those kinds of things. 7 physicians in the downtown area approached U of T, and these were chiefs of medicine who asked for an NP role, an acute care NP role at that time. Eleanor Ross was the chief nursing officer at the time at Women's College Hospital. She had been president of RNAO. She was on the committee. I joined her on the planning sessions for that. And that program began in 1994 and ran for 5 years. It was a postmaster's program. You had to be sponsored to go into the program by your physician that you worked with. And it was a crash course in NP work. It was, the initial program was 4 months long. So for 5 years, and it's a master's NP program now. So once again, things evolve. So you can see the acute care NP program started prior to the Coupon NP program, which started in '95. And that was a consortium of 10 universities, and the impetus for that was from Ruth Greer, who was the Minister of Health, and she still had a nurse practitioner caring for her who is cross-appointed here at Mac and takes our students in an Etobicoke clinic still. And it was her idea around the changes that were needed in terms of evolving healthcare, especially in primary healthcare, the whole movement towards healthcare reform and the movement towards looking at primary prevention, of really instituting this role. And Alba DiCenzo's here certainly provided a lot of impetus from her research in pushing this through. So in 1995, the first programs began, and it wasn't until 1998 that the legislation and regulation actually occurred. So there was a period of time in there, just as with the physician assistant right now, where there were primary healthcare NPs, and that legislation, by the way, was only for primary healthcare NPs. So we still had the group of acute care NPs like myself, without any regulation, no legislation. I had a letter from the Medical Advisory Committee saying I could order anything that had to do with pain and symptom control, chemotherapy for a stable patient. That's all I had to practice on at the time. So pretty precarious when you think about it today. What really started moving things along again was from 2004 to 2006, the Canadian Nurse Practitioner Initiative, which really brought together a pan-Canadian group to develop consensus about articulating the nurse practitioner role. And from this came the definition that we use today about what a nurse practitioner is, and that is registered nurses with additional educational preparation and experience who possess and demonstrate the competencies to autonomously diagnose, order, and interpret diagnostic tests, prescribe pharmaceuticals, and perform specific procedures within their legislated scope of practice. Now that initial legislated scope of practice you might think was broad, but it was very narrow. We had a drug and lab list, which was for the primary health care again, which was always 2 years behind because it had to go through the legislature to get passed. So, and even then, nurse practitioners couldn't prescribe necessarily first-line drugs. They were having to order second-line, third-line drugs because it wasn't on the drug and lab list. And a strange example is Twinrix. A nurse practitioner could not give Twinrix, but could give them separately. So, you know, there were things that just didn't make sense even within the practice at the time. So since this CNPI, which, as I say, was a major turning point for the NP roles, the introduction of a national core competency framework in 2005 was an important deliverable of the CNPI. And the framework was recently revised in 2010 because then we had in 2008 the legislation or regulation which included the acute care group finally. And we've moved away from actually saying acute care versus primary health care, although they're different but similar in some ways in terms of education, but we're looking more at population. So family all ages is the primary health care. We have NP adult, we have NP pediatrics, and those NP adult, NP pediatrics may work in primary health care, they may work in acute care depending on their background and what their focus is in their educational program. And not to mention the most defined NP role is probably the neonatal nurse practitioner role. It is the most defined role with a specific population and has been very successful since the 80s. And continues to be. And my colleagues who are acute care NPs are nodding their heads. It is probably the most defined role that is there. So what's happened as well over the last number of years is that the regulators, that each province had its own set of exams, etc., to regulate the practice of NPs. There was a move to move that under a Canadian umbrella. And so all of the provinces now have given up that exams that each student would write in their own province to a Canadian, pan-Canadian exam. So it's all standardized in terms of that way. So there's the family all ages exam, there's the NP adult exam, the pediatric exam, and the neonatal nurses are writing. They used to write the licensing exam in the US, but the US sort of turned the switch off of that happening anymore. So they're writing an exam from Quebec at this point. So in terms of the PA, and certainly in my literature review of the group, there are similarities in what they do. There are differences certainly in the two cohorts, what they are. Our group of nurse practitioners, they're all, I would say, the average age is 35 to 37. So you can see that they come in from nursing with a breadth of experience coming into the NP program. They're in many ways experts in their area when they come into the NP program. So they've already developed that basis of patient care assessment, not advanced assessment, but assessment. And the biggest move, I would say, as well in the last number of years, and it took us 7 years to do it, was to move the primary healthcare NP program from post-baccalaureate education to a graduate level education. The acute care group was always, it began postmasters and then stayed at the master's level, combined with the NP education. So the biggest and distinguishing difference between the two are probably cohorts themselves, what comes into the programs, but also exactly what John had talked about. It's this legislation and regulation of the role that is hugely absent at this moment. But I know behind the scenes that this is in the works to happen. And it certainly has happened in the US, and we've even seen in the US, you may have a PA with an NP working as a dyad versus an NP with a physician. So it can work. And certainly the literature I looked at, there was one specific one I looked at, it's Canadian because there isn't much literature about the PA role in Canada. But Ducharme had written, he had looked at NPs and PAs in ERs, emergency rooms. And certainly from what got looked at, whenever you add an NP or a PA to the mix, outcomes were better. Benchmarks were met in terms of being timely access to care. Wait times were reduced. Less patients walked out of the ER that had not even been seen because of the existence of a PA or an NP in healthcare. So I guess one of the things I wanted to say is that we have a lot of sick people in communities, in hospitals, and we need a lot of different types of providers. One of the big things we do need to look at, which has happened in the NP group, and the NP group has probably been the most overstudied of all healthcare professionals in many ways. But we do need to go back with the PA group and do some of that research again. What activities do they perform? What are the outcomes? How do they compare working with an NP with a physician, a PA with an NP, within a multidisciplinary group? How does that look? What are the outcomes from that? Are there efficiencies? And we need to respect each other's differences as just that. There are differences, but we need to work together in the healthcare field because I think the public are demanding it. The public are asking for seamless, timely access to care, quality patient care. And I truly don't think patients really spend the time we do worried about who's looking after them as long as the outcomes are consistently good. And so that's why some of the other things about nursing had an awful time when NPs started. Nurses felt that NPs would take their jobs. And the Ontario Nurses Association was fairly vocal that we were poaching nurses to go to NP roles because they needed so many nurses at the bedside still. So it's almost history repeating itself, some of the rhetoric, and part of this is our own, the way that we've been brought up and we're socially constructed and wired that a doctor's a doctor and a nurse is a nurse, and we need to start thinking differently about that because once again, healthcare is changing, the healthcare milieu is changing, and we have to respond to all of this. So I'll stop at this point. I probably will join some other things as we go through for the discussion. Thank you.